Case management and the effectiveness of current electronic health record use by Selena Troop. Case management. So case management programs have traced back as early as the 1800s. Case managers have different abilities. They help people, inpatient, outpatient, with the discharge process, after the discharge process, following up. Some of the tasks they do are a lot of social needs, such as housing, transportation, food insecurities, creating strategies to improve their health, and come up with a plan to decrease rehospitalizations, making sure that they always are having their medications, taking their medications, can afford their medications, things such as that. Research has suggested that case management services are extremely effective in helping to reduce the healthcare cost, as well as improving patient outcomes, also improving, patient satisfaction as well. The services can be offered in different settings: health insurance, hospitals, physician practices, community health organizations. I myself work as a case manager currently, and I do work for a health insurance company on that aspect of it after people have been discharged from different facilities. Situational analysis. So electronic health records, also referred to as EHR, are pretty much used in all aspects of healthcare. There is no more paper charting. They have transitioned all of that over. President Obama is the one in 2009 that kind of made this push and started offering different incentives for people to switch over to electronic health records. Unfortunately, the current records offer very little interoperability, which decreases the quality of care due to lack of collaboration between different providers treating a patient. So sometimes what a PT, physical therapist, is putting in, the nurses may not be able to see that same note. Sometimes the records just don't carry over through both disciplines. Another drawback would be people are still worried about their healthcare privacy. There are very many breaches. Recently, we had a huge healthcare system in my area that got attacked by ransomware, and they were with no records for 2 to 3 weeks. The people that worked there were not getting paid because nobody had access to any hours that they previously worked. They could not clock in, they could not clock out. It put anybody who had ever been in that health system, it put all of their information in jeopardy, which were millions of people. It's such a very large system. So definitely making sure that systems are as up to date as it can be to decrease the risk. Also, there is no database that contains all resources available to case managers. They have to go in 20 different avenues to look for one specific type of information. Digital technology has been making nurses' jobs easier, but there are still lots and lots of things. There are still errors. It's not 100% effective, but over time it's getting better and better. Like I said before, case managers are having to use multiple systems to access the most up-to-date information, test results, past medical history, current providers. If there was one big universal system, it would decrease the number of errors. You wouldn't have to worry about the patient's primary doctor and endocrinologist both pulling, labs, getting A1Cs, things like that, because they work for different health systems. Everything would be in one lump system. The workflow requirements: a more efficient and adequate system to assist case managers in patient assessments, care, and documentation. Include all necessary aspects of the patient's medical record. I think it should be a universal system where all records are in there. So a nurse can log in. Patient John Smith has been to 3 different hospitals in the last year, and you're able to pull up the records from all. Instead of having to call and get them sent over and go through that process, you can pull up what they were diagnosed with 8 months ago in a different health system. You can pull up different medications that they have taken or different medications that were prescribed to them over time. Not ones necessarily that they're taking, because a lot of patients get prescribed medications that they just refuse to take. we need to be able to access all of it. So at least a discussion could be had about if they're back, especially if they're back in the hospital for something that could have been prevented if they took that medication. So having access to everything would definitely help out. There are more than 100,000 case managers working in the United States right now. Many work remotely. I am one of them. I don't even have to leave my house. I do everything via telephone and my computer, and my telephone is rerouted through my laptop. Knowing, you gotta know as much about your patients as possible. So right now, in order for me to do that, I have to go into 3 to 4 different systems to be able to get recent claims, current medications that they have filled, that were paid for, rejected, any of that. Also, my regular system that has all their information in it. So I have to go in different places to get all what I need. It should be able to be accessed by all providers treating the patient, the physicians, the therapists, the nurses, social workers, even the billing department. They should all have access to this universal system. But the most important thing would be when you log on, it has to be a very secure system. More than just a password. Right now, I have to use something besides my password called a token code. It is an app on my phone, and you have to go into that app, and you have 30 seconds to put in this token code that's given, or that token code expires. So you either have to be fast logging in so that you can get that token code active, or wait for the next one to generate and do it that way. And it's literally a different code every 30 seconds. So it's about as secure as it can get. After logging in the system, you want to include all the active patients in the system. You can't look up, if you have a friend down the street staying at a different hospital, you shouldn't be able to have any access to that patient's information. Only the patients that are active to you. To prevent people from being nosy and being able to illegally look up different patients' information. This universal health record protocols would be to be aware of patients with the same name, to watch out for look-alike, sound-alike medications. The nursing handoff would require 2 signatures, which would mean the nurse that's leaving is signing, saying, I'm handing off to the ongoing nurse, and the ongoing nurse is saying, yes, I'm taking responsibility for all of these patients. Especially, not even just nurses. I've seen it in the CNA world, where the ongoing shift does nothing but complain about the previous shift not doing their job, and they wouldn't sign off on that until they could have done rounds and made sure every patient was clean and dry and taken care of. Also, don't forget to complete your charting before you go home. Certain aspects of the charting would have to be completed before the nurse would go home, but a management would have like an override code for extenuating circumstances. And also a huge alert if any out of range alerts come on. If the patient's vital signs, anything like that, is out of range for what the physician sets is considered their protocol. Architecture alternatives. The first electronic health record was established in 1972, which is a huge step in improving healthcare, but many didn't start using it until it became an incentive in 2009 to transition over. Implementing a new electronic health record system is a challenge and will affect everybody involved: administration, healthcare staff, patients, families. Everybody's affected when having to switch from one to another. There are many pros and cons in this process, which I will address on the following slide. There are many mitigating strategies that can be used when going from one electronic health record to another to reduce unintended consequences and maximize patient safety. One way should be to pair with another healthcare system temporarily during the transition to lessen the disruption to patient care. So being able to use both systems while the new one is implementing would definitely help a smooth transition. Also, having staff that was pre-trained on this new system before it even rolls out will help it go smoother, because as nurses get stumped in different aspects, they have somebody that they can call and say, hey, I need you to come here. I need help with this. Some of the pros and cons. Pros: nurses will have access to a current record of all patients' current medications. Nurses can have access to all diagnoses a patient has ever had. They use scenario-based training to learn the new system with, like fake patients, improving patient and provider interaction and communication, more convenient access to everything you need right at your fingertips, and more reliable medication prescribing, fewer opportunities for medication errors due to illegible prescriptions. Many times I have received prescriptions for patients and I couldn't even guess what the doctor wrote on there because it's barely any scribble. Some of the cons are everyone will have to learn a completely new system. The staff will need extensive training to be able to completely understand and work on the new system. Learning a new system can increase instances of adverse events and reduction in the quality of care until the staff fully know how to use the system. The facility would incur a higher upfront cost to purchase the new system as well as a higher rate for monthly maintenance fees. There would also be a disruption to the staff workflow while the transition is being made from one system to another. Some of the provisional recommendations when planning to create a whole new system to replace the current system. You need to take advice from people who are working on the front lines. Ask the nurses, ask the techs, ask everybody on the floor some of the things they find difficult or would like improvements in, and use that feedback to try and help create this new system. Also speaking to case managers from different facilities to get their input on the struggles that they deal with to try and come up with, a better aspect from that angle. One of the future recommendations for this new system would be to offer a patient satisfaction survey during discharge. Having a tablet or an iPad or something that they can bring into the patient during discharge to have them complete their survey right then and there. If they send it out 4, 6, 8 weeks later, patients won't necessarily remember anything. At least during discharge, it's fresh in their mind, and you'll get a lot more participation. I know when I get surveys in the mail, if I've had any type of hospital stay, I never fill them out. I always end up just throwing them away. Also, not having them be 10 pages long with 30 questions. A quick 5, 6, 7 questions, straight to the point, shorter, simpler, because not everybody gets big words. Everybody needs simple. I know the town I live in, which is very rural, there's still a lot of people that can't even read. So if they did it with the nurse could actually read it to the patient if necessary to be able to get an adequate response. Another valuable feature would be explored deeper would be something called health mining, which uses various clinical and research applications to track the progression of a disease, health risk predictor, and adverse event detection. So trying to figure out why they keep coming back to the hospital instead of just treating them and sending them home, figure out the reason. If they're having an asthma attack, maybe their house hasn't been cleaned in a year and it's covered in dust, and the dust is an allergen for them and it's causing them to have an asthma attack. So being able to come up with different resources. Maybe they are eligible through the VA for somebody to come clean twice a week and they just never knew that it was available. So being able to kind of access all that different information will definitely lead to better patient outcomes. And the bottom one, like I just said, about treating the current issue, but also looking for available resources to prevent from happening again. And some of my references which are available here, I used different sites and different references to access. Like some of them are from an eye doctor, or some of them are, different aspects to get specific information. It's not all just cut and dry. Thank you.